care of these 80 children or more at that time. And we actually wrote a paper on rheumatic fever at that time, 1963, I think. But anyway, so that seed was there, that this was interesting. And then when I thought about it some more, I found it is an interesting field for several reasons. When I went back, now I had to tell you some other story too, but I hope you don't mind. But before I come to that, what made me be there when the opportunity was there is that here is some multi-system disease. I always like to take care of a whole child, global look, not parts of the body. And also this one is a multi-system. So I thought this would make me a better clinician all around. And I'm sure many of you know pediatric rheumatologists are some of the best diagnosticians because we can deal with any particular organ to some extent at least. We won't say, okay, this is nose, and so if it is a lung, you go to the specialist. We know something to begin with. And it was also, my personality was not for a one-time visit like emergency room or acute care. I like a continuity and getting to know people long term. So this was a possibility. And of course, the other important thing was, there was not even a specialty. We knew nothing about these diseases. Sometimes now I wonder, even with all the advances, we're still struggling to understand them. So it was a challenge into a new field. But then, what is the opportunity? I have to tell you, I was, after training here, I came back to India twice to settle down. And after the second time, when I came back to say, no, I'm not going to go back, stay here, the question was, I was interested in academic and research and teaching. And actually, if my interest was purely practicing, I would have stayed home in India. But this one at that time was opportunity, and I was at Children's Philadelphia, and I'll tell you the other story later. But anyway, when I went back, the question was, what do I want to do? Because it had to be a specialty of some kind for academic research. My background was in virology and immunology. We're talking 1959, 60, when I tell you immunology was such that we did not even know there was something called IgA. And that was the time. So but anyway, that was the training at that time. And how do you use it? So I had two superior guides for me, Dr. Coriel, many of you may not know him. There is a Coriel Institute for Medical Research. Anyhow, he was more like a father to me than a teacher. So I always had discussed with him on these. So we were talking and he said, well, with your background, virology, immunology, pediatrics, you can go to infectious diseases or oncology or rheumatology. So those were the options. So I was thinking about that. Rheumatology was new. There was not much. There's a challenge to do something. And Children's Hospital Philadelphia did not have rheumatology at that time. So when I came back and they gave me some jobs to do, and I said, I'll do it if I can also start a rheumatology clinic. I didn't know why I said that, as you know, I didn't know much about it. Actually, Dr. Coriel was saying, very few people know anything about it anyway. So you have the background, just go ahead and find it. That was the way he said it. And Dr. Bangiovanni, whom Dr. Raghupathi knows, he was the chairman of the department. And he said, well, go ahead, start it. And that's how it happened.
Amazing, sir. Amazing.
Was it clear? Did I talk slowly enough?
Yes, very, very clear, very clear. That's amazing that your journey from pediatrics to pediatric rheumatology.
Yes.
Started off in La Rabida Hospital?
For children, yes. Chicago.
Dr. Raju mentions that it has an interior design of a ship. Is that so?
I don't remember that. It was so long ago, but I do know La Rabida means the lost frontier.
Ah, okay.
That's all I know, but I don't remember. It's right on the lake. They're still there, but it's a chronic disease hospital now.
Okay, okay. Very interesting, very interesting. So you said you had interest in research at that point of time. That's the reason why since you started off the pediatric department in KMC Manipal, and
Yes,
subsequently you stayed there for a very short duration of time before you moved
correct,
ahead to
correct,
US once again. So
correct.
was it the lack of research facilities in India at that point of time which prodded you to move away from India?
That was, well, as I mentioned, I was very interested in academic teaching, research,
Mhm.
etc. Not just, practice is absolutely important. Of
Right.
course, I respect those who practice. But
Mhm.
my inclination was on the other side. I needed to go.
Mhm.
And as I said, it was 2 times I tried and went back.
Right.
So the story is a little bit more complicated than that. But fact is, I went back.
Mhm.
Yes, academic freedom, academic research
Mhm.
were the motivations.
Okay. And Eri, I wanted to hear thoughts about contemporaries in the field of pediatric rheumatology because you're one of those doyens of pediatric rheumatology, and you would have had interaction with Dr. Brewers, Dr. Barbara Ansel,
Yes,
and Dr. Eric
yes,
Bywater. We only
yes,
see their names in the textbook. We have never come across them. So it would
yeah,
be nice to hear about your thoughts about the people who started off pediatric rheumatology world.
yes, yeah, correct. Any,
So,
you want me to
what, what,
start?
what, what would be your thoughts about your contemporaries? Means you have had personal interaction with these
Yes,
doyens yourself.
yes,
You're one of those first few people who started off pediatric rheumatology.
right,
So,
right.
what are your thoughts about, say, Dr. Barbara Ansel or Eric
Okay,
Bywater?
okay. Yes, we were fortunate to be part of the early group, and I still recall the meeting, American Rheumatism Association, now it is called American College of Rheumatology. And we were hardly 12, 13 people at that time. And most of them were internists, actually. As you may know, many of the people who helped develop pediatric rheumatology were internist rheumatologists. And I'd known them, but I'll mention some names that I know them, professionally interacted, but never knew them well enough. But I'll tell a few more things about people whom I really do know personally. I'll start with them. The first would be, without any doubt, Earl Brewer. He was absolutely a true, what do you say, a Texas gentleman. Absolutely. He's from Texas, as you probably know, Baylor. And he was a great organizer, doer. He was absolutely superb in getting things done. And he's definitely the force behind the Park City meetings. Actually, the story on that, many of you may know or may not, the Park City meetings became Park City meetings because when they started, we didn't have any money, just we used to go on our own, meet together and get this going. And Earl Brewer was a skier, and he had his own property, house or I forget, apartment in Park City. And he said, "Yeah, let's meet there and plan our meetings," and that's how it started, and that's why it's called Park City meetings. And he's definitely the force behind the pediatric rheumatology collaborative study group. At that time, hardly 10% of the medications available in the PDR were approved for pediatric use. And we had a big time with our rheumatic diseases. He says, we need to test them. How do we do that? And I remember being part of some of the early studies on tolactin, indocin, etc. And so I would say he's a big organizer and a gentleman. He knew how to bring people together, real savvy. Uh, uh, since you asked that, there's one other point that is the pediatric rheumatology. What it is because of the absolute collaboration, the feeling of camaraderie between the folks there at that time. And it is still there. So I'm very happy to see that. Anyhow, he's with me, my first one, because such a good friend. I miss him. Then the next one I knew that well, reasonably well, is Jim Cassidy. I don't know how many of you knew. He was an internist. He took the American Board of Pediatrics, became a pediatrician. He was the chairman of pediatrics in Nebraska. And, we all know him as a pediatric rheumatologist, but he was an internist to begin with and tremendously interested. And gentleman, educator, editing, you have to see, my goodness, anything goes into his hand. You don't know how it'll come out after he edits. English, superb. And of course, all of you know the textbook. He's the American Board of Pediatrics, he was very much involved in. And I forgot something else about Earl Brewer. 2 or 3 of his great students are Dan Lowell, Ed Giannini, and Carol Barra. They all have contributed. And of course, Jim Cassidy, you think of Ross Petty. He was his training. I do know Barbara Ansel not that well, though I spent 3 months with her during my sabbatical. Difficult to know her. She was obviously a phenomenal mind, my goodness, a visionary. He was an internist too, and by original training. What I admired most about her was that absolute memory about anything that she saw anywhere. You had to present a patient. She, oh yeah, I saw one in Poland like this 20 years ago. And she could correlate all of those things immensely. So that's what I found about her. Jane Scheller, very involved with the organizing the first Park City meeting, and she's known for uveitis and ANA. And she just faded away. She lives somewhere near Vancouver, but I've lost touch with her. Then Virgil Hansen, he was the chief for LA Children's, absolute gentleman, clinician, another force behind the first Park City meeting. And his focus was on rehabilitation, which was needed in those days so much more than we know now. Then there were others, Jerry Jacobs, and of course, all of you know Lauren Potman. My goodness, she's still going strong with her research on dermatomyositis. And others, Eric Bywaters and Joe Levinson from Cincinnati, who is also an internist. I can go on and on. Thank you for asking.
So the salt this salt city meeting happened in 1976, if I'm not wrong.
Yes, yes.
And we have only seen pictures of it. It must have been a legendary place because that's where the actual birth and naming of pediatric rheumatology happened, isn't it? So
absolutely correct. Here is the first volume that I knew you may ask about it. So I brought the original summary of that conference, 1976 March.
Okay. So,
no, actually the meeting happened before March, but this is publication March.
Okay. So the subsequent, I wanted to understand, how do you visualize the subsequent development of pediatric rheumatology from the time you first got into it in the early 60s? Now it is 2020. So it's been 5 to 6 decades that you've been seeing progression of pediatric rheumatology. How do you visualize it by your eyes? How can you talk about how the development of pediatric rheumatology happened from its nascent days in 1960s to what it is now?
Yeah. Before I go try to answer that, do you want to see if anybody else has any questions from what we have talked? Is that okay?
Yeah, definitely, sir. Definitely. If anybody has any questions with the topics which we have discussed, please go ahead. It's an interactive meeting.
Video meeting. ఈ టైంలో అందరికి మీ జూమ్ మీటింగ్ అంతా ఆన్లైన్ మీటింగ్.
Anybody wants to ask any questions? If there are no questions, please. No questions. Please go ahead.
No question. That's okay. Fine. So the question is, what is the development since those days?
Yes.
That tough one. So, I'll give an overview of what I see looking from now backwards. We made enormous progress, unbelievable progress. from the days we started. You know, if I just have to give 2 or 3 small examples, we started out with maybe at that time we had only 3 medicines we can think of. Aspirin, gold, and steroids, that's it. And yes, of course, insulin was there, but it was not looked upon with favor for various reasons. Chloroquine was there, but again, concerned about toxicity, side effects, etc. So we really had no look at how much we have. And in the first 15 years, if I remember, we had at least 12 children whose joints were so damaged, they needed replacement. We don't, and so many children with so much orthopedic surgery, hip flexion contracture, release of knee flexion contracture, ankle stabilization, cervical fusion. We don't see any of those things now. How much blindness there was due to this disease, with all the advances in testing, recognition and early follow-up. We have done wonderfully. And then at that time, again, as I mentioned, when I was doing my work, we didn't even know there was something called IgA. And who had heard of all the CD3, CD4 and all that? And I was listening to Dr. Agarwal's talk the other day. We have so many molecules and things which we see nowadays. So we have come very long way, but we still have obviously a long ways to go, because one thing that strikes me, a couple of things that strikes me, one is that even with all these things, when you look at this results on the studies and how well they do, particularly for this juvenile arthritis, the idiopathic, almost any medicine you can say 1/3 of them get better, 1/3 about the same, the 1/3 need something more because they don't respond. That's about the same thing whether it was methotrexate or whatever comes up. So why is that? So we still have that. The other thing that I've always been thinking about, and it is showing up more and more, is, with some of the newer things with monoclonal antibodies and specific drugs working at a specific signal transduction molecule. I was looking at Amita's slides. You look at them all the way going up and down, loops and forward loops, backward loops. For us to think that I can touch one point there, nothing else will change, it's not, doesn't agree with me. So, and I'm not saying you shouldn't use them. We should, but it's bound to have some side effects somewhere. On this, we got to be aware of that. And in terms of going, of course, the pediatric rheumatology collaborative study group and all the outcome of that, and then the Printo, CARA, and more collaborative work, more and more basic research. We have come a very long way. I'm so happy it's all in your wonderful, beautiful hands for the future.
Thank you. Now, you have been interested not only in pediatrics, but pediatric rheumatology, but you have had a keen, as you earlier mentioned, that academics has been a key area which you have focused on. How have you visualized pediatric development or pediatric training development over the last 5 to 6 decades now?
Yes.
From the time, say you were a undergraduate student in Madras Medical College.
Yes.
What it is now, till the time you retired, how do you visualize it? American system, Indian system. What is it that you see over the last 6 to 7 decades has changed?
In the medical education or pediatric education?
Medical education, as well as pediatric education.
Okay. You gave me warning, so I did have to think about it a little bit. Medical education in general would be good, and then pediatric education, obviously, is a part of it. Incidentally, I know about this only as I know in US. I've been in India several times. I've spoken with many of you, but I don't claim to know that. But here, but it's applied to India too. The first thing is the exponential increase in knowledge since we started. I still remember our our textbook of pharmacology, which was hardly this thick. Now, it's unbelievable. It's not only the amount of material one has to learn, but the rapidity with which things keep coming. But then we also have information technology tools, which makes it somewhat easier to manipulate this amount of information. So what I'm seeing is the preclinical education is changing rapidly, and it should you cut down the time spent in some of the preclinical assignments. And actually, I don't know, some of you might have seen an article within the past month on where the future education should go, at least in this country. You find that they want to introduce clinical from the very first year and do most of the preclinical material in different ways. One is some of the subjects are covered before coming into medical school, like genetics, statistics, etc. And then you also know how there is no more dissection in many places. It's all visual, three-dimensional, virtual anatomy, distant education. So those are some of the things that have happened over the years. And then I find the students who come in are also come differently. In the sense, now at least, it's true in general, but pediatrics, definitely more women are into it. Now it's about 60% or more trainees are women. And many of them are more rounded. They've had much broader education. Some of them have done their own research or some work somewhere. And all of them are absolutely savvy with technology. So whenever we have to, oldies like me have to give a talk, we always ask the chief resident to come and to set it up. And they all have more solid base in basic sciences like statistics, genetics, etc. And what else can I say? Information technology has made a big difference in terms of how to look at literature. It's good, it's also bad, in the sense when we are talking in the clinical thing, I see that sometimes irritates me because you say something, somebody's immediately thumbing the pad to find the literature on that. And of course you'll get something. As usual in medicine, you can take any position, you will always find an article that supports your position. So is that the way to do? And then they look at the abstract. They never go into the detail to say whether it is real. So those are some of the weakness portion of it. What else is different? Clinical training in, at least here. Am I talking too much?
No, sir.
Is that okay?
On the topic.
Okay.
Right on the topic.
What I see is a clinical training. I will have to divide it into many portions. Students are still very good here, good exposure. But we also realize that at least here, more and more patients admitted are more seriously ill, very unusual, one at a time, where you cannot learn general medicine and pediatrics, and therefore there is more pressure to get the education in outpatient settings and offices, physician offices setting, etc. And also trying to get more emphasis, unlike what it was before, on cultural competencies, social inequalities, and the effects of that on health, mental health. These are getting emphasized more. Residency training is still good, but role models are fewer because there's not adequate support academically, even here. And overemphasis on the lab tests, and I'm sure many of you know, I don't know what it is there, but here many of the inpatients are taken care of by so-called hospitalists who keep rotating every 8 hours. And how are you going to learn anything without continuity, either of patient or of the teacher? So it is a weakness in my view. The economics and something is driving that. Fellowship trainings are still good, excellent, I would say, but now, as all of you know very well, it has become harder and harder for foreign medical graduates to come, unlike my days. I guess that's about all I can say, unless you have some specifics thing you want to ask.
Dr. Amita has a question. Do you think
Yes.
medical education has the breadth but not the depth?
Let me think. I have to think about that a little bit. Can you help me a little bit more, Amita? What is it that you're, when you say breadth but not depth?
Now, what I find most students know very little about everything, but when you ask them any questions which has depth, they are absolutely blank. So as you said, that the people are glossing over abstracts and titles of the journal articles, but they're not reading it and understanding the depth of it.
Absolutely correct. If that's a question, yes, I already mentioned it. Yes, I do feel they all, as soon as you ask, they all will get you an article somewhere. But then when you ask, did you read it? Is the study properly done? Are the conclusions correct? And more important, is it relevant to our question? Very few can answer. Yes, that's a problem. You know, when you have too much material, it's already known. If you have too much information trying to collect, then the depth is going to be, unless you spend time.
On the same note, Dr. Chetna Khemani from Goa has this question. Thinking Skills for Digital Generation was a book written by you.
Yes.
And would you, in the same context, would you like to give a message or a comment about this in the same context, wherein there is so much of digital information, but to process that information, we need to have that depth, which is lacking.
Yes, correct. Thank you for asking. And it is a special interest for me. And actually, Anand was going to ask that in a different way, but thanks, you asked me. That book was written together with Dr. Crystal Lamuza, who is professor of education and chairman of the department at the University of Delaware. She has her PhD in use of information technology in education. So we talked about this, and I have always felt for a long time. Did I go off the screen?
No, I just put up the books which you have written. Dr. Raju was kind enough to share all the books which you have written, and I put it up there. No, you're on screen. You're on screen.
When I've always thought this from the very beginning, from getting into medical school and particularly during training, that we have to know, or talk, particularly seeing some superb clinicians, it was a question how you think with what you get and how you get the information. And lately, somewhere after 80s, 90s, I started wondering, particularly after TV came, we had bombarded with information. So actually, as you probably know, the European Union has started a specific academic study on information disorder, because I think we are living in an age of information disorder in the sense we have not only too much information, but we have disinformation, misinformation, dangerous information, useless information. So we feel that one of the most important things for the future generation, all of you and your children, is to learn how to get the correct information out of this. You have to go through it, but you must have a way of quickly sifting through, saying this is nonsense, and go to the correct, reliable source to get the information. Then having done that, how to think about it. So here there are a couple of things. One is that we are bombarded with information because now it is easy to create, nobody to monitor or quality control, easy to disperse. And so anybody can put anything on the screen. And what has been known for centuries is there are always people who want to sell you anything, whether it's a product or a ideology or whatever. They are going to try to make you think their way. And what is worse, now we have, I don't know how many of you heard the word sculptor or a wordsmith. So these are people who specifically work on creating words which will hook you. And actually, there is this whole laboratory called Persuasion Laboratory at Stanford. And so I feel it's our responsibility to get the information and think on our own, not be led by anybody. So that's the reason we wrote that book. We want people to know, it's not a big deal. All of us can think. We don't expect. It's just simple logic. And then, more important, giving time to think. And even more important, thinking about thinking. In other words, so, okay, you made a decision, and then after you make the decision, you have to make it, obviously, quick decision. And then you can say, okay, this is a quick, then think about it later. How did I think? Is there some other way I could have thought about? So that kind of thing. So that's the emphasis on that book. Thank you for bringing it to the attention. I don't want to be selling books here. Thank you.
Dr. Raju has a comment to make. Dr. Raju, are you there? Hello.
Dr. Athreya, great to see you in great shape.
Good to see you.
It just made me think that when I see your title on thinking skills in the digital world and the information blast that you spoke about, would you think or imagine that when you put both these facts together, the way medical curricula are shaped today, especially in India, there's a whole load of facts that we are taught in medical schools that we perhaps don't need to know, because that is information that can be easily accessed when you need it. I mean, just for example, doses of drugs.
Yeah.
Okay. These are not things that you need to remember anymore. When you need it, you will go and find it. That's just the most elementary example I'm giving.
Correct.
But the act of knowing the 14 causes of nephrotic syndrome is not as important as identifying it as nephrotic syndrome and then going to read and find out how to approach it there later on. And this could perhaps reduce the training time in a medical school and make them more a problem-solving method. What are your comments there?
So if you tell me we don't have to use our brain like a filing cabinet, that's what you're saying, which is, yeah, it's true. We don't have to remember every one of those things. However, as you said, we have to know where to go get the correct information to think with. Yes, so there are some things which we don't have to be spending time teaching because they can certainly go and get it. And teach them a lot more about how to get the correct information, how to analyze that information and apply it to the situation. Those techniques will be more useful for them, yes. At the same time, I would say that for some things you must have a backup too. So technology can fail. So we need to have some backup somewhere.
No, I not for a moment am I saying that there has to be such a radical change, but it's just that what you must know, what you should know, and what you can access, to divide it into 3 such groups.
Very good. I agree with you. I agree with you. Although I must say this, that there is a study, very interesting one, where what happens is you can think with only the information that you have in your head, but no use saying it's in the computer. So there is a little problem. There is at least one study, a lot of time people say that they know, but they really don't know. They just know it is in the computer they can get.
Dr. Jagdish Chinnappa has a question. Dr. Jagdish, are you there?
Yes. Okay.
Dr. Jagdish? Okay,
Hello, can you hear me?
Yes, I can.
Yeah.
Yes.
So it was wonderful hearing your experiences about the growth of rheumatology.
Thank you.
I'm a general pediatrician and I'm probably one of the few general pediatricians in this rheumatology forum.
Wonderful.
And,
thank you. Welcome.
And I'm quite impressed with your. I didn't know about this book, which I'm going to, go and get it first, because I've been fascinated with people like Pat Crosscarry and others who've been looking at how our thinking skills are warped in many ways. And I don't know whether we are going on a model which should be very different. See, we started off with medical analysis in terms of anatomy and pathology and physiology and etc. But I think the newer generation will go in straight to genetics and metabolomics and other things before even getting to anatomy. What are your comments on that?
What do you mean in terms of education? Or?
No, the whole structure of thinking might change completely. In terms of defining the disease from its more genetic basis and its metabolic basis rather than getting into even anatomy.
In the future.
That's right.
Well, it's probably true. You know that already, at least in rheumatic diseases, we see that all the time. Almost every day we find a syndrome caused by a mutation or whatever it is. And yes, as we advance more knowledge, you can guess that we can find some defect in one of the steps in any one of the pathways. And it'll be one patient in 20 million, whatever it is. But those kinds of things will be coming more and more. But that you will recognize only by knowing the common ones and then realizing this doesn't fit that pattern. Yeah, it will be. And my guess would be, who knows the future, but yeah, more and more genetic basis, metabolic basis, and the molecular, the signal transduction molecule basis. And I would even venture to say defects in the three-dimensional structure of proteins and how they fit with each other. That even, it's already happening, I think.
Thank you, sir. Thank you.
Dr. Dharmanand has a question.
Okay.
Dr. Nagaraj and Dr. Dharmanand, clubbing both of them together.
Yeah.
When you started off, you mentioned that there are only 2 or 3 drugs, gold, aspirin, and maybe one more drug for treatment of rheumatic diseases. And then there was nothing called as DMARD then. And subsequently, Dr. Dharmanand has this question. Could you have imagined future at that current future? What is current was future then.
Yeah.
Could you have imagined that we would reach this level 4 or 5 decades back?
No, not really. It's as usual. Futures, it'll be future. But the hope was there. All of us were absolutely. That's the reason for whole thing. All these efforts is hoping that these kinds of things will happen. And
uncertain, but there was hope.
Absolutely, it was on hope and hard work and everybody working together, and new fields open up and new concepts come, new instruments come, and I still remember the first time I ever used a MRI to recognize the edema of the muscle. It was not there before, so it is amazing.
The other strong area for you was the clinical bedside skills.
Yeah.
About which I think you have written 3 books, if I'm not wrong.
Two.
And 2 books. And these books how much change do you think has happened from the first time you wrote the book in 1980 till 2020 now? The art of bedside skills. What are your thoughts about that, and what is your give away message to us clinicians and the trainees who are joining us here regarding the art of bedside medicine?
Yeah, okay. Yeah, I would rather talk about my own feelings and how it evolved. See, the word clinical, I'm sure many of you know, but anyway, the word clinical comes from the Greek word klinikos, which means the bed. So it's a bedside medicine. So bedside medicine is obviously a patient suffering, one child, an adult. So to me, clinical medicine obviously is an art because you are looking at the whole situation. And clinical medicine should encompass a global view of the patient and also the way we think. And so for me, when I'm saying clinical medicine, when on the side of looking at the patient, so the child side, I must know the disease as described in textbooks. And then I must know the illness. In other words, how does the disease behave in this person? You know, how does the child manifest, how does the adult manifest that particular disease? It'll be different from, because that comes into some of the behavioral issues and how to help them. And then what is the social background or cultural background in which they are? And we have to have that global view. That's one of the reasons I like pediatrics, because you have to look at all of these things. And that, so collecting information on all of those things is part of art of clinical. And then on my side, as a physician, I must have good listening skills first and foremost, observational skills, analytical skills, decision-making skills, helping, caring skills, communication skills. They are all part of the art of clinical medicine. So all of these have to be there together. And that is a lifelong learning. Everybody teaches, patients teaches. Actually, many, many lessons from patients. And to me, I always believed, and I was absolutely fortunate to have, so we didn't have time to talk about them, some super clinicians, both in India and here. And so the only way you can do that, I think, master clinicians as your mentor. Modeling is the best way to teach, and being with the model is the best way to learn. So that's about it.
Right, sir.
I don't know whether you agree with me. People who disagree can please express their ideas.
No, I completely agree with you. A good model is a good teacher who is going to lead you to the right direction. Dr. Balu Athreya has a question for you. Dr. Sarbanand?
Nice seeing you, Professor Balu Athreya.
Good to see you.
I remember seeing you a long time back, 1994-95 in Madras Medical College.
Okay, good to see you.
I'm a student of A.N. Chandrasekharan and Rajendran.
Wonderful.
And you have taught us in Madras Medical College wards. So good to see you in good health, sir.
So far, so good.
And how is your interest in music going on, sir? Carnatic. I know that is your another love, second love.
Absolutely. I spent a whole 10 days in Chennai last year going to the concerts only, nothing else. Thank you.
Welcome. Bye-bye.
Thank you. Anand, how much more time do you have?
No, we have time, sir. We have about 10 minutes, 10 to 15 minutes still.
Okay. All right. Go ahead. Let's say anything. Question.
So the other question Dr. Girish had, and even I wanted to ask, you are, apart from the pediatrics and pediatric rheumatology, you also have interest in spirituality, philosophy. So how come you ventured out into these fields? Was it an interest from the beginning, from the early part of your life? So what made you, was it a personal interest?
Thank you. You know, it was there always from the very beginning. It was always there. You know, family and some of my teachers and the culture grew up in, and it was always there. It's actually, I would say that the basic philosophy drove my professional life. And then during professional life, you learn constantly from people about philosophical issues. And, you know, it occurred to me earlier, I might as well say that when I said patients teach you too. And here is one philosophy, practical philosophy, a 12-year-old boy with a spastic diplegia, about 12 years or so, and a lot of surgery and everything. I remember him talking to me one day. He said, Dr. Athreya, 12 years, they've been bothering me with my leg, which doesn't work, but I have a very good hand. Nobody's telling me what to do with it, he said. You know, it's that learning there. There are a couple. One is listening. The other side of it is we as physicians are taught, and we should, that is our primary duty, to find what the disease is, what the defect is. But you cannot help them with the defect. We got to give them the strength that they have. So that is a kind of philosophical thing from do. So it's a lifelong interest, and only thing is after slowing down on the clinical, there is more time. As a matter of fact, if you see some of the book, they were all written after I slowed down clinically, whatever was there, trying to put it in. And so that's.
Dr. Amita?
So Dr. Balu, how do you keep so fit?
God's grace, good
And what else?
family genetics thing they gave me. They were very, and it's luck in a way, you know. It's God's grace and luck. I don't take any credit for it.
Coming to the family, how was your life as a child? Any events which made you what you are currently, Dr. Balu?
Oh, I know you were going to, and I was going to duck that question. What's the use of talking about personal autobiography? I would rather think that helps other people with ideas rather than personal life. And if you say, who are the people who influenced you? What is it that you learned from them? That will be a lot more useful for everybody. So if there's interest, I'll give you a couple of examples.
Please, please.
Okay. Actually, this is something I should have said before and I forgot, but the point is none of us do whatever on our own. There are many people involved in building you to be what you are. And I was thinking what made me get into research, and I should have given them the credit. This is something many of you may know, may not know. When I was in third year medical school at MMC, Dr. A.L. Mudaliar, who was the vice chancellor of the university, had invited a WHO team to come to MMC, stay there for one whole month for education and build this. And you will be surprised who were there. The person in charge of that group was Sir Alexander Fleming. And Carl Heyman, who was another Nobel laureate for his work on carotid sinus thing, was there. Sam Levine, who was the chief of pediatrics at Bellevue, was there. These were the team. There are about 10 of them. For a whole month, listening to them was what fired me up on the science side of it. So that you can see what the influence was. And very few people seem to remember it. I tried to get hold of some picture from the old papers and all. I couldn't get it. But that was if you had asked me about medical education, MMC, I would have mentioned that as one of the big ones. Then in terms of other people who influence, I already told you one patient example, teachers. Dr. Sanjeevi, who was the chief of medicine at General Hospital, and the house surgeoncy was with him, Dr. Sanjeevi, and his assistant was the famous Dr. K.V. Thiruvengadam, whom we call KVT. Many of you may know, he's an absolutely superb clinician. It was the solid foundation in clinical medicine was laid during the time with those two people. What a clinical thing. Dr. Sanjeevi, of course, was socially very conscious. He's the one who used to take us. I've gone with him on Sundays on providing medical service in villages around Chennai. I'm talking about 1954, 55. And so social consciousness he gave, and he started the voluntary health service in Chennai. And then Dr. Thiruvengadam, amazing clinician. I still remember making rounds in the evenings. Can I talk some more, or time is up?
No, please go ahead. Please go ahead.
Our admission days were Wednesdays, and all morning we'll be in the clinic, and whatever admission comes that day goes to Dr. Sanjeevi unit. Dr. Thiruvengadam was assistant. And then we'll come back in the evening, and about 8 o'clock, Dr. Thiruvengadam will come, and he'll go bed to bed. And just staying there, listening to the way he asks questions, you know what he's thinking. And then he will write notes at the bottom, about 3 lines or so. You cannot write a summary of a case description like he did. And then he will tell us what are the tests we should do. And we're 3 of us house surgeons. We'll work on those blood and urine. We did all of those things inside lab. And that was solid learning. Then there was Dr. Achar, and he's the one who inspired me to get into pediatrics. The final year medical school, rotation in pediatrics, the very first day, I knew this is my field because of him. That's what I mean, teacher. And the way he did, and in those days, at least at Chennai, there was no children's hospital at the time. You had to have a notebook where you keep case histories for, I forget how many. It was a pleasure doing them with him. And he was a master clinician too. And the way he will do again give you one example. I hope you don't mind all these examples. You're tricking my memory, you know. But say, looking at child, the one I remember, child with the empyema in those days, and he'll be touching. Of course, now percussion is gone just as well. You know, I'm not for all old ones staying on when we have better ways of finding. But anyhow, he would, the first, you know, he'll do the percussion and then he'll touch. I'll go down his hands on the back of the chest. He'll go down and then he'll tell me, come and touch here. See, at this level, the skin becomes a little different in texture and it is warmer. This is where the level is. And that was before x-rays, you know. So that's because that's all they had. They didn't have all the ultrasounds and MRIs. And so that's the kind of clinical. And that bomb at Wadia Hospital for Children, Dr. Merchant was unbelievable clinician too. So those are some of the masters. And then here too, I've had some super. So those are the models that I'm thinking about in role models, and not just being a medical, but humane, compassionate care. Anyhow, that's it. Sorry.
And Dr. Dharmanand mentions Dr. Thiruvengadam is still alive.
Yes.
He's
there.
In good health.
He's not such good health. Every time I come, I go to see him. He's also fortunate. I've been very fortunate with some of them. They become more like more than just a teacher, and he's an inspiration. So I go every time I come and see him. We communicate very well. Yes, thank you. Yes, very fortunate in that.
So, Dr. Suma had this question: do you still follow research and pediatric rheumatology now? Keep reading about.
Absolutely. See, I stopped doing clinical about 8-10 years ago. And I still used to go once a week to the hospital for the clinical conference and take part in pediatric rheumatology, etc. But last July, I stopped that also. My vision is a little problem and driving is, and so I'm not, but I follow literature. Yes, I do.
Sure, sir. If anybody has any more questions.
I have something I want to close remark. Is there time? If there is time, otherwise it's okay.
Dr. Sujata has this question: have you learned more from your mistakes or successes?
You know the answer. Yes, by mistakes you learn more. Definitely. Yes. That's where the thinking skills come, thinking about thinking. That was an advice given long ago and by Hostler. You take a notebook in your pocket, write your cases, and then after the final diagnosis is definite, go back and see whether you made it right or wrong, and if so, why. And that is thinking about thinking.
True. Agree. Can't agree more than that. And Dr. Balu, you had something to say.
Yeah, I do. If you with your permission.
Definitely, sir. Definitely. Please go ahead.
There are a couple of things I want to just share as a closing remark. You know, I don't mind telling you, I'm 87 now. Who knows how much more? Every day is a bonus at this point. And so this is an opportunity, and I wanted to just share some of the things been in my head for a while, and you're giving me an opportunity.
Dr. Athreya,
yes.
Athreya, if I may please intervene.
Yes.
I had the most pleasant experience of having coffee with your brother, who I think was 92 when I met him.
He's 99.
He's 99, and he's still as sharp as a button.
No, sorry to say.
Okay. Okay. Well, at least about a year or two ago, when I had met him at your home in Bandra, he was very conversant.
Yeah, but not any. He's failing definitely. But yeah. Thanks for asking. Yeah. I'll tell him. So some of the things I want to share with you. One is, I already mentioned it. I feel in the future we have to use the information technology wisely. It's a wonderful tool, but I think it is being misused at this point to influence people to all kinds of ways and do horrible things. And so we have to learn how to use it and how to think with it. That's number one. The other thing I want to share is, as we go, people are saying that all the time, and now it's after this pandemic, I'm concerned that it may be even more of a truism that the social divides have become just too much everywhere, all over. And and how can we get good medical care to everybody, comprehensive, coordinated care with compassion. I think that needs to be one of the focus for future, for society in general, not just medicine. Actually, I was listening to a Dr. Gayatri Vasudevan from Bangalore. She's part of some group called LaborNet. And she was saying exactly the same thing. She's concerned. She's saying their group is working with 20 million migrant workers and truck drivers in India were stuck wherever they were when the lockdown came, suffering, no place to stay, no food. And she's concerned too that this economic disruption may create more divide. So we need to be, I'm concerned about it everywhere, not. The other thing is this pandemic has definitely shown how fragile human life is and how impermanent life is and how interdependent we are. And maybe this is an opportunity for us to rethink and reimagine the future. And you know, I was thinking, and I've been talking to some of the people here. I live in a senior citizens home. I've been talking with them and I'm asking, what is it we have learned from this pandemic? Other than the fact such a small little thing can disrupt the whole humanity. And then maybe this is a chance to do something different. So what do we wish the world to be like in the future? And if it is so, what are the things we have to do? That means what are the values we want it to reflect? And I really would like, I'm saying this because of the situation we're in, and I don't know what the answer is. Nobody has the answer, but this may be a time to think about it. So thanks for giving me the opportunity. And I don't want to talk like a preacher, but I am concerned.
Thank you so much, Dr. Balu, for a wonderful description of the current scenario and whatever your past reminiscences were, which gives us clues about how to go further in our life, how to lead a good life, like the way you did, the way you have served humanity, the way you have helped others to come up in life. I heard Francisco Julian praising you a lot, and he's come a long way in life. And I'm sure a lot of us hearing you will be motivated to become good souls, good clinicians. Thanks so much for spending your time here with us, and we hope to see you in India very soon. Thank you so much.
Thank you for giving me the opportunity. Thank you, and
Namaste.
namaste.
Namaste. Namaste. Thank you so much. Thank you.
Okay. Thank you all. Thank you all for coming.
Thanks to everyone who's joined us today evening. Thanks so much.
Bye.
Bye. Bye-bye. See you.
Thank
Bye.
you, sir.
Bye.
Thank you all.
Thank you.